It's kind of interesting. We started off with nearly 30 people. Last week we had 15. Right now we have 5. It's kind of interesting how it trickles down, and it makes you wonder, is like, are people getting value out of it or they lose interest? Now, one of the things that my marketing person that I work with tells me is that most people buy online courses and don't finish them. They start them and don't finish them, which is really interesting. And then, it's like, okay, why is that? Why is
That's how gyms survive, through attrition.
Well, why is it that we invest in something, but then we're not getting our full value out of it?
Well, for me, it's accountability. That's why I have to make the live ones, because I know I won't watch the recordings. Yeah.
Good to know thyself.
Yes.
Yeah. And this is the thing also, is like, we also have an accountability for our clients, meaning that they're accountable to show up to their appointment on time. They're accountable for paying us for our value. They're accountable for taking care of themselves and doing their own work, because we can't do the work for them. And so there's different ways that we hold our clients accountable also. And so by that same standard, we have to look at ourselves. And this all comes back to that idea of we have to be our own client self. If we have an expectation for our client's accountability, how does our own accountability show up? Because they're going to be reflective of each other. And this is something that's related to boundaries, how we set our boundaries. If we're unable to set clear boundaries for ourselves and those around us on how we want them to interact with us, then how other people set their boundaries around us is going to be reflected by that as well. And so it's always like a mirror. There's all these mirrors that are going on. Hey, welcome everyone. Nick, I see Nick. Uh-oh, I see Dax. I need glasses. Saadra, Alex. Hey guys. Welcome.
Hi, Joseph.
So we're going to continue this process.
Hi.
Hi, Rhonda. We're going to continue this process of providing an experience for our clients. Today, what I wanted to do is 2 things. First is get some feedback from you all on your process with the material thus far. And the second thing is, let's do some demonstrations of these principles that I'm sharing with you on test, challenge, retest, how to use client TL, how to engage with the client to look for the satellites, the important pieces that are going to give us a direction or our entry point when we're working with our clients. And so, as I was saying earlier, this course is really for you guys. And so that means that I need some assistance from you in pulling out my experience so that I can share that. And the way that happens is by your interaction and your questions. And so that's what we're going to start with. I'd like to hear from you all about what you've gleaned thus far from the previous 2 sessions, and what questions or specific directions you like to go in. Like, for example, there might be a specific aspect of structure that you'd like to gain some new tools to share with your client. Whatever it might be. And so I'm going to turn this over to you guys so that you guys can ask some questions.
I can go first if you wish.
Sure, sure.
So I haven't really been using the test, challenge, retest on clients as of yet. I've mostly been focused on myself and how I'm moving and working on my own movement, asking myself my own questions, trying to take this time off to focus on my own movement problems, which I have many. And so the questions I have are really more for myself, and using this as sort of a platform to engage myself to be my first and best client, so that I can sort of like work on my own. Someone get someone mic out. All right. So I can work on my own healing. So I could take this to my clients once I have it sort of more dialed in. That's where I am at with this material at this point. But I'll have questions toward the end, I'm sure. I always do.
Right. So you're looking at being your own client first.
100%.
And how
100%.
that's working.
What's that?
Hey, Alexis, welcome.
You ask me how it's working?
How it's working for you as far as your own process, and are there places that you feel that you're making good headway, or places that you feel like you're getting coming up against your own barriers?
I'm definitely coming up against my own barriers in some places. So what I'm doing is using the self-indicator to know when I'm at that barrier. So if I'm in a place where it's kind of uncomfortable, I'm working with my neck a bunch and doing some of the neck stuff we're working on, that I'll know that I'm in a certain spot, and I'll go and I'll actually rework that until it actually becomes a better, more positive indicator when I'm in that range of motion. So yes, I'm going to say I'm having some really good strides with my own movement. Also taking some of this time to work on some of my own personal emotional stuff that I've been sort of putting off by the wayside during this pandemic that we have here in the world. So just really focusing on myself, trying not taking too much material outside of the stuff that I have been wanting to focus on mostly with, because everyone's like pushing a lot of free material down everyone's throat, and it's really, really great. It's a great community. But I find that it's like if I go to the Louvre and I'm there for 8 hours, I don't see any art. So if I'm there for 3 hours, then I can see a couple nice pieces and, get some good information from that. So not to overwhelm and internally focus on my breathing, on my movement, how I'm breathing when I'm moving, and then indicator testing to see if that is something that's a false positive, or I'm become hypertonic or hypotonic. So that I feel that if I can really push this into my own self and my own body, I can really take this to my clients once this really, especially in New York State, we're kind of in a bit of a shit show. That we can actually use this as I'm hands-on as well. I've been practicing some with some online people, but again, I'm not trusting my indicator as much when I'm working online with other people. So I just take it to basics. And what you and I, Joseph, have talked about is like toning down the nervous system, having a conversation about toning down the nervous system, and not trying to fix things online, because it's unless you're really just a genius and you have great psychic ability, which I do not, nor am I a genius, but yeah, just playing with my inner self.
Yeah.
And it's working well.
Yeah, the big satellite that I heard there, Scott, is about developing your own personal practice, meaning
Correct.
the time that you take for yourself to work on yourself. And I think that as body workers and people that are bringing this kind of information to our clients to help our clients, we're really in a place where we need to lead from the front, meaning that we have to do the work ourselves in order to guide our clients on any kind of path. And without that foundation of our own experience, what's happening is that we're using unrealized knowledge. It's like we learn something, but we haven't earned it.
I agree with that.
And there's a bit of a difference there. And so what does it look like to create your own practice? For me, there were many, many years that it was getting up at 6 a.m. and from 6 a.m. to 8 a.m. was my time to explore myself. There was a couple of different facets of that. One is journaling. What is my experience? What am I going through? What is the emotional context of my life? How am I responding to my environment based on that foundation? The other aspect of that is movement work. Now, movement work has different connotations for different people. Oftentimes, people will have an association to movement as exercise. And then exercise has another connotation of work production. How much work we produce becomes the quantitative value of our exercise. We need to re-examine that, because it's not necessarily the quantity of the work that we do, but it's the quality that in the long term is going to make the big difference. And so when we start looking at the quality of our movement, we start looking at how our structure, how our nervous system is integrating with the goals of our movement. This really needs to start with a foundation. And that foundation is the capacity of each joint to respond appropriately to movement. This is going to be the foundation of why our clients experience discomfort, because there are one or more joints that aren't participating appropriately in the movement equation. Then other joints and movement become overworked as a coping strategy. And so through our own practice, we start to discover how each joint should appropriately move. Now, there's some great bodies of work out there. I was fortunate to study with Dr. Eric Cobb and Scott Sonnen in the early 2000s. And that work completely changed my lens, because I went from a classical applied kinesiology manual muscle testing lens, which looks at movement in a snapshot, in a particular position in which you're lining up joints, levers, and connective tissue structures, and you're evaluating how those connective tissue structures are responding in that snapshot. We don't move that way. We move dynamically. Does our structure and our nervous system have a concept of that? And so this becomes the whole reason for, one, the 5 primary kinetic chains, which leads to optimizing assessment. How do those kinetic chains actually function in real life, rather than this arbitrary, oh, the psoas is a hip flexor when you have the femur externally rotated 30 degrees with a 30-degree abduction. Well, you know, when do we move that way? When are we in that position? Actually, never, virtually. except for maybe Nick, he's a soccer player. There are times when he's passing the ball or juggling the ball where he may hit that position for a split second. But more so, most of us, we need to have stability while our psoas is in eccentric function during the push phase of the gait. And so why is it then in standard kinesiology, they're talking about the psoas, evaluating the psoas with someone supine, which is the closed position, which is the end of the swing phase of the gait. The power and the expression of movement has already occurred by then. What about evaluating someone prone and looking at the position of the femur in relationship to the pelvis prone? That is going to be a more real application of how we're looking at this relationship of the eccentric lengthening of the psoas so it can store elastic energy so that it can be expressed in the swing phase. And so this lens really needs to change by this understanding of joint movement. And the way that we're going to understand joint movement is through our own practice. Now, there's a great resource on YouTube. Coach Sonnen has put all of his Into Flow, his beginner series, on YouTube. I highly recommend you getting into that work so that you can start to have a different appreciation of how joints move. Then with that lens, you can start to discern what players are involved. This becomes a very different thing than saying, oh, I want to evaluate your psoas, your iliacus, your tensor fasciae lata, your adductor longus, your pectineus, your sartorius. If you're looking at hip flexion, it becomes a very different thing when you start to see someone's movement. Then we can look at what players are involved in that movement. Who are the concentric players? Who are the eccentric players? What has to isometrically stabilize so that those eccentric and concentric players are able to express load and work production? Does this kind of make sense? Yeah?
Totally.
Okay. So so that's kind of like, I know a little bit of a tangent and a spiel, but it becomes our lens that we're looking through as we're observing how our clients are moving. So let's put this into some practice. Before we do that, does anybody have anything that they would like to share before we ask someone for a demo?
The only thing I guess I could share is that my self-indicator sometimes is accurate and sometimes not accurate. I can double check my work and first it gives me a yes, then it gives me a no, then it goes back to yes, and it goes back to no. And so I'm like, how am I going to use this on a client via Zoom when I can't even get a correct answer from me?
100%.
And I'm so used to visually being able to test very lightly with my hand and feeling I could get a correct answer and checking it via directional testing or reciprocal inhibition. But here, I'm going through the screen and it's like, okay, I'm going to give them the wrong thing to do, make them worse.
Right. I completely agree with that. So what's the answer here? What's the answer here? Don't use an indicator. You don't need to use an indicator. This is why last week I taught therapy localization. We want
Right.
to use the client's experience as our benchmark.
Right.
If we're using our experience as a benchmark, we're disempowering the client to make change within themselves. We're saying, oh, I see that you need to do X, Y, Z, rather than having them do X, Y, Z. What do you notice different?
Okay, so you're saying the client's experience, meaning I have them do a single leg stance and they're severely pronating, let's say. And so I'm going to have them go ahead and stimulate the peroneals and then have them do another single leg stance, and I'm going to base it off of that. I'm trying to get what the client's experience really is.
Right. So that's a mindset that you're looking for a problem that you want to release for them so that they can get better at whatever movement. We want to.
Well, then I don't know.
A little bit. I know what you're saying. I understand what you're saying. We want to shift that lens a little bit and use therapy localization instead. So what that means is, instead of releasing that peroneal or fibularis or whatever we want to call it, we would have the client do that light brushing, do a couple of strokes of light brushing, come back to the movement. Did the movement improve?
Okay, so we're just stimulating it without any pressure or anything.
Right, because if the movement doesn't improve, that's not going to help them. This is something that actually happens a lot in the therapeutic application, is that as a therapist, we I'm going to ask you, Alexis, to turn off your to mute for a second.
Sorry about that. We got two people working.
That's okay. That's okay. What often happens in a therapeutic process is that as a therapist, we have a premise. I see an overworked structure and I see an underworked structure. I want to do some release work on the overworked structure to see if the underworked structure improves. In essence, this can be appropriate. However, what happens is we put too much time and effort into releasing and not enough time into the experience of getting that particular movement that was not able to participate back in the game. That's actually the most important thing. And so what we want to do with that is do just a little bit of stimulation to see if that particular movement can get back in the game quickly. Now, there's something that we want to consider. The nervous system is brilliant and it's fast. Muscle tension is never the problem. That's the symptom. It's the symptom of the nervous system having a coping strategy in which it needs to support structure. If we give the nervous system the right information, it can change so fast. It's unbelievably quick. And we don't have to get in there and release muscles or release connective tissue, because the nervous system does it on its own when it feels safe, that it doesn't need that coping strategy.
So, okay, let's use the single leg stance again as an example. So I'm visually seeing that they're pronating. I have them swipe on the peroneal muscles or whatever we want to call them. And So we see that improves. And then, so when you say don't release, are we going to give them, say, let's stretch these muscles that are facilitating and then activate the tibialis? I mean, where do we go from there? Are we still going to do the same thing as what some of us have been trained in, or are we now going to shift differently?
Well, there's a combination of things. We do need to make a shift, and we need to make a shift in understanding the hierarchy of the nervous system.
Right.
So here's the important bit, Alexis. Muscle response is always a symptom of the nervous system. Why is the nervous system responding the way it's responding? When we start looking at the structure of survival and importance, and this has to do with the various kinds of receptors, ligaments and joints will always trump muscles.
Right.
Right? So this is why we want to get into stimulating joint capsules and ligaments, because when we do that, that is going to do the work that we would have done with muscles.
So basically, you're going to go up the chain of command.
Yes, we want to go up the chain of command.
But that takes tactfulness because, you know, let's jump back to an in-person session. Someone comes in and they're complaining about, say, hip or ankle or knee pain, and you want to go first local and let them know you're acknowledging their problem before you start going elsewhere and they think you're a complete wacko. You know what I mean, right?
I do, and this actually comes to the way that we shift our lens in our assessment process.
But I think you helped me understand this enough. I mean, I haven't developed any online clients yet. Everybody wants in person. They're like, oh, I'll hold off. I have one client who's interested, but he doesn't have right now the time, so I'm developing it just in case. Where I can take it and see.
Yeah. So here's what we're going to do, is we're going to look at some other ways that we can use an assessment process that doesn't necessarily have to utilize this idea of our client in a neutral position and we're palpating. We have to assess them dynamically. And this comes to, you know, joint response, how the joints are moving. Now, if we remember what we did with Scott last week, we looked at neck mobility and the relationship of cervical rotation. We just looked at one motion of cervical rotation. There are many, many different motions that we could be looking at with those joints. There are 4 basic movements of the cervical spine. We have rotation, we have flexion extension, we have lateral flexion, and we have translation. All those movements work together. We want to be able to use that as our lens to isolate what particular movements our clients are having trouble with. And then we can use our TL techniques to find out what that person needs to get those joint movements back in the game. Now, for many of us, we're going to find structure isn't enough. We're going to need more in our toolbox to integrate those movements back in to their structure. And what I mean by that is, in applied kinesiology, there's the trine. There's the trine of, there are structure correlations, there are physiological correlations, and there's limbic associations and emotional correlations. Guess what? Structure is at the very bottom of our survival needs. If you start thinking about our physiology and the four circulatory systems, which is our pulmonary, our cardiovascular, our lymphatic, and our cranial, cranial fluid. Sometimes my mind bounces. Anyways, those four circulatory systems have greater priority for the nervous system than these muscles. However, the muscles are going to reflect if there's a problem in one of those systems. And so if we're treating the muscle and there's a problem in the system, but that system is using that muscle as a coping strategy, a way to boost the energy requirement that lack of integration in that other system needed, we're removing from the nervous system its strategy. When I talk about keeping the container safe, that's what this is all about. And this becomes a very important thing that we want to, recognize. Are we working on the right thing for our client? And we can use our TL to find out. And that's what I'd like to do right now. So I'd like to take us through a process, and I'm going to need a volunteer. Yes? Okay. Now,
Okay, can I volunteer?
Yolanda, is your name pronounced Yolanda or
Yeah, Yolanda.
Yolanda?
Yeah.
Okay, great,
Yeah.
Yolanda. So
Yeah.
I'm gonna wait. How do I don't know if I can change my screen so that I have you full size.
If I'm talking, then it will probably stay on. If you switch to, let me see here. At the top right-hand corner, there's either kind of like a segmented box, and then there's like a 9 little box thing at the top right-hand corner.
oh yeah.
And if you enter full screen, the person who's talking will probably be in full screen.
Yeah, I pinned my video.
Oh, okay.
I need to see if I can, there's another setting. Spotlight, okay. Okay, so I'm spotlighted. Okay, now let's try that and see if that worked. Yolanda, can you speak?
Yeah, I can speak now.
Okay, yeah. No,
Can you see me?
that's okay. I can see well.
Okay. Okay, I'm gonna mute myself for a second so I can just yell at my kids to try and be quiet. Or you're going to hear singing in the background like through the entire time if I don't tell them to be quiet. Okay, so just hold on.
Okay, well, don't yell too loud. Be nice.
Joseph, can you pin her video? Can you pin her video?
I don't know if I can or not. Oh yeah, I can. Let me see if
Voila.
it works. Oh yeah, perfect. Thank you, Scott. I've got to go close my door.
Thank you, Ariel. Thank you, Ariel.
Sorry, I apologize. He gets really into his singing and he does not hear me then.
No apology necessary. No apology
I'm
necessary.
just gonna move. I don't know if I have to.
Okay, so Yolanda, tell me about what you'd like to work on today.
Oh, hold on. Now I muted you. Can we hear him?
I can hear you fine. And I've got,
I can't hear you, Joseph. Just hold on a second here. Oh, sorry. Had headphones in.
I was going to say, is your headphone jack still in your device?
Yeah, sorry. Bit of a blonde moment there.
That's excellent.
Okay, go ahead.
So, what would you like to work on today, Yolanda?
Okay, so I have right about here, it's always painful. And then I know if I do like a lateral raise, then I can feel it in here. So it might be a combination of things that are going on, but it's literally if I do an overhead press, this left one is significantly weaker. I've worked on it with rotator cuff. It seems to be more of a scapula type of thing. But yeah,
Yeah.
there's range of motion issues. Pain, tightness, like kind of ongoing, 0 to 10, probably a 3 constantly.
Yeah. So, I want everybody to take a look at the white space. Do you know what I mean by white space?
Yeah.
The white space between Yolanda's left ear and shoulder and right ear and shoulder. So
Can you put Yolanda on the main screen? Because I can't see her.
I have her on, I pinned her on mine.
Let's see. Oh, where are you here?
So if you go to her
Oh.
square.
I see her now.
Okay. Great.
Okay.
Yeah, so
Sorry.
as I'm looking at Yolanda's shoulder, now I'm also recognizing that right now Yolanda is seated on her pelvis, right?
No, well, I'll sit now on my pelvis because I was on my knees. Sorry. Now I'm on my pelvis.
Did you lower the camera?
Yeah.
Okay. Well, that changed it a little bit too. So if we look at the left shoulder and we look at the slope of that left shoulder compared to the slope of the right, notice that the slope looks longer. And the white space between the left ear and the left shoulder is further. It's like the shoulder is slightly more depressed and rotated. And if you also look, if you look at the notch where the levator scapula and the upper trapezius come in, there's like a more pronounced indentation of tension. Can y'all see that? Yeah? So to me, this talks about how the scapula is hanging on the structure. Now, Yolanda, have you had any shoulder injuries, falling off your bicycle, getting, running into things with your shoulder, any of those kinds of things, impacts?
I started playing rugby last year.
You started playing rugby. Now, did the pain in your upper cervical spine did that happen?
Yeah.
Was that there before or after?
I think I had this injury beforehand because I had a rollover car accident probably almost 19 years ago. And I think that I've always had this because I smacked heads with I was in the driver's seat with the other occupant in the car. And I had quite a bit of like when I went to the chiropractor, and it's never been the same since. And I work landscaping during the summer. So this last summer, I started with the combination of landscaping and rugby, and I got crunched good in rugby, they figured I fractured, like almost did a baby fracture, not the normal fracture. So yeah, there's a few things.
Yeah. So that was super interesting. Did you all notice that when Yolanda was talking about the rollover accident, her head tilted and moved away from the left shoulder? Yeah. This is a satellite. Okay, so now this becomes a premise that we want to explore. So what we're going to do is I want to get more of a perspective of Yolanda's scapula. So I'm going to have you turn around for us so that we can see your scapula. Can you move your camera a little further from your body so that we can see more?
Does that work?
Yeah, that's pretty good. I'm going to ask you to tilt your camera down slightly, right? I can't see the trailing angle of the scapula. There we go. Okay. So does everybody see that the left scapula is more winged, and it's also, if you look at the lat activation, there's more activation of the lat and the teres minor. Also,
It's pretty.
also we can start to see that the space of the lumbar is more compressed on that side. So there's the head moving away and the lumbar moving towards. Okay. Now, Ilana, I'm going to have you raise your left shoulder up towards your ear. Good. And bring that down. And raise your right shoulder up towards your ear. Now, did you all see the difference in the way that she organized doing that? She initiated her movement with her cervical spine, with her left, and on her right, she initiated the movement with her scapula. Okay. Now, I'm going to have you take your right hand and put it on the side of your head where you hit your head when you were in the accident. Now I'm going to have you raise your left shoulder towards your ear. Good. And now remove that right hand and raise your shoulder towards your ear. You see that, guys? And then place the hand back on and raise the shoulder. Okay. So this is what I know from that. That impact 20-some years ago is affecting scapular stability. This is what we want to start to vet out and see what's going on here. Okay. I'm going to have you turn for me so that you're facing me because I want to show you some movement. So we're going to look at the scapular stability in 3 different planes of movement. I'm going to turn sideways so that you can see me. We're going to start with the sagittal orientation. So there's up, down, or elevation, depression. There's protraction, which in sagittally orientated is the scapula is coming forward. So the pec minor, the serratus anterior, and the lat are working together to bring the scapula forward. And then there's retraction. And this becomes a circle. So we have a circle in one direction and a circle in the other. In Feldenkrais work, they call this the shoulder clock. The shoulder clock happens in 3 different planes. The next plane of action is the coronal plane. The coronal plane is a little bit different than what we would consider the coronal plane of the body because the axis of the scapula doesn't sit on the axis of the spine. It sits on the axis of the rib cage. And so in order to do this, if this would be my arm would be in the coronal plane here. I want to bring my arm slightly forward, about 15 degrees. And now my arm is in the axis of the scapula. From here, we're going to look at those same movements: elevation, depression, retraction, protraction. And that becomes a wheel. And then we'll change direction. The third is the transverse plane. For the transverse plane, the scapula is going to roll up and over towards the opposite hip, and then it's going to roll back. And so we have up and over and down, up and over and back and down. So front and down, back and down. These are the three motions that we want to assess. Okay. So let's start with the sagittal orientation. So the arm will be straight in front of you, and you're good. Yep. Now here you want to use your thumb, Yolanda. You want to use your thumb to create a saber grip, and you want to make sure that your elbow is slightly active and that your wrist is neutral in alignment with the long bones of the arm, so that your wrist isn't flexed or extended. So it's neutral, like if you were going to lay your wrist down flat. Yeah. And the elbow lock. Why? Because the elbow will compensate for lack of scapular mobility. You see it? So here's what's happened. The cardinal direction of protraction forward. Yolanda's scapula is unable to do that.
It's hard.
Yeah, it's hard, huh?
Yeah,
Okay,
I have to
now-
really think about it.
Yeah. So now you're going to take your other hand and put it on your cranium, and you're going to go through that again. Oh. Markedly improved. You notice how Yolanda wasn't clenching through her jaw when she was trying to find protraction.
Yeah, it was markedly easier.
Markedly easier, right? Okay. So this is where it's going to get a little bit tricky. The scapula is the symptom. The cause is what's happening in here, the impact here.
Yeah.
So now, what we have to do is we have to ascertain what's happening here. Okay. So now, granted, I'm working differently with Yolanda than I would in a client practitioner relationship, because I'm sharing with you all a process rather than just doing the process. Yeah. Okay. So now, what I'm going to have you do, now, unfortunately, this actually requires, as a practitioner, to be able to use an indicator, because we're moving into an area where we cannot use direct movement assessment. So I'm going to qualify my indicator. What is yes, what is no? Does my indicator respond to skin stim? Yes, it does. So my indicator is normally responsive. Now I'm going to have you just TL in the clear on your head. My indicator is off. There's something going on there. Remove your hand. My indicator is back to normal responsive. Now, I want to find out what is going to negate Yolanda's this TL in the clear. Right? You guys following so far? If you guys aren't following, I need you guys to say something so that I know. I'm going to have you take your hand and put it on your head again. Now I'm going to have you take your other hand and put it on your forehead. I'm getting a no. Remove that. I'm going to have you take your fingers, all 5 fingers, and put them together like this and put those in your belly button. Hypertonic. That's a no in this situation, right? So if I have a TL in the clear, and then go to a paired TL and the nervous system goes hypertonic, that means that it is driving the volume up. We want to be driving the volume down to normal. Okay? So this 5 fingers in the abdomen is the global TL for physiology. Bennett points, hand on forehead, is the global TL for limbic association. I have eliminated those. Now I know that it's something structural. Okay? So now what I want to do is I want to go directly to that region. So this is going to be tricky. So you're going to put your hand on TL. Now you're going to apply a slightly more pressure and let that release to normal. Okay. Go ahead and release that. What did I just do? I did the anti-stim for nociceptors. So now I have to find out which particular nociceptor stim that we need to do to bring Yolanda's nervous system to normal. So you're going to put your hand here, and then you're going to take your other hand and you're going to take your fingernail and you're just going to poke at your skin. Good. That normalized it. Good. Okay. Yeah. Okay, so the next thing that we're going to do is you're going to take your fingernail and you're going to tap around that area on your head. Good. We have now stemmed it. Now what I want you to do is go in the same area and do brush. No. Okay. Now, are you going to be able to reach that region behind your back? Can you touch that region where you feel the pain? Yeah. Okay. Good. So, you're going to poke. And you're going to come to the other side where your back is, and you're going to rub gently, just a gentle rub. Good. Okay, now this is going to be, this is going to be weird. You're going to need to do both of those at the same time. You're going to have to figure this one out. Yeah, good, good. Now I want you to breathe. As you
It's a bit of a tapping on the belly button and rubbing.
Yeah.
I'm just like,
It becomes a very different thing than when we're as therapists doing it for our clients.
I'm like trying to tap and rub at the same time.
Oh yeah, it's like chewing gum, huh?
Yeah, it is.
Now,
Because my
with
hands
each
are
breath,
cold.
I want you to take some long, deep breaths, right? Because why do we do that? Because it stimulates the ligamous connections in the diaphragm, which helps upload the nervous system with this proprioceptive information. Good. Now go ahead and stop that. Bring your arms down. Okay. I'm going to check my indicator. I'm normal. Now you're going to TL in the clear. Yeah. Good. Okay, now you're going to come to your wheel. Excellent. Excellent. Now you're going to turn back to me, please. And you're going to lift that left shoulder towards your ear. Markedly better. Markedly better. What are you sensing in your scapula?
It's working.
Yeah,
I mean, it's just, I don't have to think about it anymore. Like
Right.
before, like when I would do this, I would literally have to mentally kind of group together going, hey, PS, you're going to do this.
yeah. So if I was in a real session, I would have gone through all three of those motions before I employed any kind of corrective. So this is about how our receptors are providing afferent information to our nervous system, and our structure is responding to that afferent information. It's not muscles. Muscles are the symptom, and this becomes a very tough bit.
The interesting thing is I actually have like a scar there. Like it's because when we hit heads, there was enough force to break the skin. Like I had stitches,
Right.
like quite a few.
So right. So the reason why scar tissue creates these neurological glitches is there is a matrix of receptors in our skin. There's our nociceptors, there's our touch receptors, the Pacini receptors, vibration receptors, and interstitial receptors. Those are the most abundant receptors in the body. These are the free ending receptors that have this capacity to morph into any kind of stimulus that the nervous system may need. When the skin gets disrupted and the scar tissue lays down collagen fibers, it disrupts these free endings, and these free endings then are sending these aberrant signals to the nervous system. And the nervous system is responding to those aberrant signals as if they are real. What we did with Yolanda is we started to give the brain new proprioceptive information about the signals that were being sent. so that that place in her shoulder did not have to overwork to try to support that afferent information from the impact in the scar. This does not mean that we actually fixed the problem in the nervous system. It just means that we've toned down this particular aspect of the relationship. There could be more, but this is a great starting point. Now, for some of you, what I just did may not be in your wheelhouse. What can we do instead? We can be less specific, meaning we can just hold this energy here and do a gentle circle, and hold this energy here and do a gentle circle. And you know what? That's going to accomplish the same thing. We just got more specific by tuning into what particular receptor signals are being the source of the aberrant signal. Great, great demo. I'd like to hear from you all about, how do I fix this now?
Thank you so much, because I've been having to work on this for nearly since it happened, and I've always tried working on it. We could never get to it because we would work on it from spinal structure and sort of bone structure and from muscles. And I mean, I was at physio working the muscles in my shoulder and my scapula to try and improve it. And I was like, you're making it weaker. Like, this isn't working. It was getting worse.
Yeah. Yeah. See, this is actually the common thing that's happening in a lot of therapy, is that people are working on the wrong system. We're providing the wrong afferent signal to the nervous system so that the nervous system can make change. And it becomes a very different kind of assessment process. Now, I recognize that this was really advanced, what we just did, because it wasn't a muscle or tendon or ligament based issue in the structure. So we have to recognize that if whatever tool we're using isn't working, we've got to go deeper. We've got to look deeper. What's really happening here? Now, the important thing that I want us to think about is this process of, we look at a motion, that motion becomes our benchmark. We're looking for what is going to improve that motion. Then we have to assess that thing that improved that motion. We want to make an assumption that that is a symptom of something else. The movement is a symptom. This is a symptom of something else. The impact. What happened on that impact? Now, we could continue deeper down this rabbit hole.
Well, when you started making me move, there was a lot of apprehension. And I know there's an emotional component because that accident had events linked to it that were really emotionally hurtful and had affected me. And so that's why I was like, oh, I hope Joseph doesn't make me cry on recorded, because I know that even when I had first realized how much of a trigger this was, when I had moved, I was in a Touch for Health. When I had moved this motion, it totally locked up every muscle in my body. And I was like, you need to stay away from me and not touch me. And the instructor at that time had said, okay, she just went into total freeze. So there was a big emotional component on just this movement here. So I know there's still emotional stuff. I could feel it kind of coming.
Yeah, so if we think about a couple of different things about that. The movement behavior of the scapula is a coping strategy to protect the impact. They're linked at the time of the event. During the event, there's also 3 different things that are happening. Our nervous system is processing the information of our limbic system and all the afferent inputs before the event, during the event, and post-event. We then create associations for each one of these phases. There is going to be one particular aspect of those associations. There's going to be the driver. Now, you had mentioned that there were some aspects during the accident of things that were going on. So that would lead me to believe that there's something that's happening before the event. And this all can be vetted out. I would never want to try to vet this out in an online assessment, because what will happen is we could stimulate the coping strategy in such a way that the person goes into a full-on limbic response that we're not able to contain because we're not there to assist our client. And so we want to be very careful about how we're engaging these limbic associations so that we're not taking away someone's coping strategy. We have these events that happen to us, and the association gets compartmentalized. And it gets compartmentalized for a reason, because we don't have the resources to unpack it. And if we crack that Pandora's box, we could be causing harm. And so we want to be very careful about this. That was a phenomenal example. Thank you so much. Thank you for sharing your experience with us, really.
Joseph, I had a quick question, because you said the 5 fingers on the abdominal area.
In your belly button.
In your belly. Okay, is the global TL,
Your umbilicus.
umbilicus for, it's the global TL for what?
Physiology.
Physio, okay. Okay.
Is there a global TL for the limbic system? Oh, that's right. Okay. And then what about the structural?
There isn't.
Or do we, there isn't one, so we just eliminate those.
There are global TLs for different receptor types, but not for the structure itself.
Okay.
So those are the only 2. Did I miss another one?
No. This is why I use that as a process of elimination. If it's not limbic and it's not physiological, then I know that it's going to be in structure.
Right. I've used the limbic one, but then I didn't know really so well where to take it. I mean, I've obviously done the NKT way, but this one, I never heard of the 5 fingers there, so that's great to pick up.
Yeah. So this becomes a whole nother thing, is how to work with the limbic system. And I'm really cautious about the way that I share my experience with working the limbic system, because it's such a potent tool, and potent tools like this have the power to heal, and they also have the power to harm. Like, for example, if we unpack someone's association and they're not able to process it and put it into a context, it can blow up their life. And this is something that's important. And and I've had the unfortunate experience of my life being blown up, seeing other people's lives being blown up by work. And then as a therapist, seeing a client whom, because of my interaction, their life blew up. And so there's a responsibility that we have as therapists to use our interaction in a way that is first rule of thumb, or first rule is first do no harm. And so
Well, there's a good thing for me. Where my office is, I'm surrounded by psychotherapists.
excellent, excellent.
So I've had a few patients, obviously with limbic issues. And I see a lot of visceral manipulation, also people with extreme gut issues. And it tends to always be, almost all seem to have limbic issues.
Right.
So I had one client, I really couldn't help him. He got angry because I told him, why don't you take a look at some of these therapists here in my building, and maybe you can schedule an appointment to talk through things because I'm not qualified to help you there. Got angry. He wrote me a bad review.
So this is the thing that we want to be able to learn, is that talking through is not effective, right?
Well,
Because
you know what I mean.
I do.
But I'm not qualified to
I get
help
it.
him with his issues.
Yeah, I want to speak to this a little bit deeper for us all. And that is the majority of the associations that we have that are affecting our physiology and our structure are non-conscious. And so talking through things has a limited benefit because it has to be conscious in order to talk through something. Now, there are ways that we can work with a person's nervous system so that we can address these unconscious associations. And we have to do it on a way that we're not trying to consciously lead that person into a process. Our nervous systems have the ability to process it on their own. It's simply a matter of cueing it appropriately. And there's a bit to that. There's a bit to that as far as safety, the relationship of movement, the relationship of what the driver is and what the main pair is. And these are all part of the things that we learn in DNA, is how we identify this. Because if we can't identify it, if we apply a tool, we're guessing. And that can be very dangerous. That could be negligent.
But let's say, Joseph, somebody does have a serious unconscious issue that's affecting them emotionally.
Yeah.
We don't know what it is because they don't even know what it is. But let's say they forgot what it is. Something happened in their childhood. Do we really want to go there?
Well,
Even trying to pull that out from their unconscious? I mean, what if it was a rape or,
right.
I don't.
We can, there are ways to going there without having it to be on the conscious level. And this is where the ability to be really good at limbic resonance and using muscle testing to ask questions. And the questions have to be non-leading. We have to first make sure it's safe to go into that direction of inquiry. And so this becomes a very, very big piece of the therapeutic intervention. And this is why it's safer to stay with structure. Because if we don't have the skill set in the toolbox, if we unpack something, whoosh, you better be able to close up that box once you crack that lid. So you're exactly right, Alexis, is that like, if it's unconscious, if we don't know that it's safe to unpack it, or to ask the question, when did this occur? How old were you? The various different ways that we can use a funnel to get to the particular event. If that person is not ready to unpack that, they're not ready to unpack it. And here's the thing that we want to recognize about this. You know, as helpers and as guides, it's actually not our responsibility for our client to do their healing work. We're just here to provide them the bits that they're ready for, the work that they're ready for. And that might just look like doing superficial work. And that's okay, because not everybody's ready to do it. Fantastic. Okay, any other questions?
I was going to say this. I think we get the ability to remember that sometimes we're not the only one in the picture, and that sometimes there's a certain timeline to someone's healing. That even though this problem's been ongoing for like 19 years, I first had used EFT, then I had used Touch for Health, I've used chiropractor. Recently, I've just done a lot of sort of more emotional work. And this, you know, it's kind of interesting when you'll start to look at what you've been through and what comes along your path to kind of help with those corrections. I just was working on some other stuff. Like, you'll have like these periods where someone might go through really intense healing bouts, and you might be part of that picture. And then there also might be someone else. Like yesterday, I was working with another practitioner on I Am Loved. That's very much heart area, right? Today, I actually get the structure fixed on it. Would the structure have released if I hadn't already corrected some of that emotional work quite as easily? You know, I don't know. But that is, you know, there's sometimes we get to be a part of, you know, one piece of the puzzle, yes, that we get to fit together. And then, yeah. And then my second question was, why did I go more hypertonic with physiology global TL? I'm just kind of curious about that.
The afferent signal took away the resources that the main driver needed, that your prime driver needed. It took away those resources, so the volume level went up. We want to increase resource availability, not decrease. We always want to be adding into the coping strategy, not taking away.
Does this mean that there could be a secondary compensation strategy in Yolanda's physiology? So when you put that,
yeah.
Okay.
And that could be what is tied to the limbic component, right? So we were just working on the structural component. And so we hadn't gotten to the place where we would challenge structure to a limbic.
Mm-hmm.
That would not be appropriate in this setting.
Yeah.
And you know, that was actually a pretty deep kind of session. But I appreciate being able to share that process with you all. Yeah, please.
Myself. Yeah, so just to reiterate that is some pretty super advanced stuff, and that everyone I see on some online forums are talking that emotions are sort of like butter. We could all just spread it around the bread. If you don't have the tools, don't go there. And I've been learning the tools with Joseph for almost 3 years now, and I'm not confident in using those tools. So if you don't have the confidence to go there, don't touch it with a 10-foot pole, because you're just going to unravel someone. And I've had people a total mess in my room, and I'm like, oh shit, and I couldn't put them back together. So just be aware of that. That's my only.
Has anyone else had the experience of working with a client where the stimulus that you provided to their nervous system had a less than optimal effect on their symptoms, like their symptoms blew up?
Yeah.
Actually, not really. I'm really careful where I go to Joseph.
Good.
For
good.
one, because I'm alone. And I've worked on quite a bit of ex-military people. And I know better than to take them there.
Right. I think
Um,
Darren Lenton's in your area.
Pardon?
I think Darren Lenton is in your area. Do you know Darren?
Darren, is he, what's his specialty?
He does PDTR and Z Health. He combines PDTR and Z Health.
I don't know him, but maybe we're in some groups. I'm mostly connected with Sarah and Simone, because we're pretty close to our clinics and we do similar things.
Great. Great.
Yeah. There's a few others up here too, but we're not so close. Or maybe our personalities clash.
Yeah. So this is something that I've learned in my experience, is that the challenges that I've had with my clients have been my greatest lessons.
I will say though, a lot of people, huh?
No, I was going to ask a question.
Oh, please.
So in response to your earlier question about have we had people get worse, in my early years as a practitioner of massage, in trying to be the best massage therapist, I would strip out all of somebody's spasm. And then they'd call me and say, it came back worse than when I got there. And so I learned that they needed to keep a portion of it, and that I had to do this slowly and educate them with other tools about how to do movement differently so that they didn't need that spasm to be there to hold them up in certain scenarios.
Excellent, excellent. And this is actually the most important thing to consider. What our client is presenting to us, their symptoms, that is a needed coping strategy. Our assessment process needs to be so that we're identifying why that coping strategy is in place. Until we understand that and we provide for the need of the nervous system to stay safe, anything that we do with that coping strategy is either going to be irrelevant for the nervous system or it's going to do harm to the nervous system. So we have to go very deep into this process. Now, because we're doing online assessment, we're a little bit challenged on what tool sets we have. And so this is why we want to have that perspective of doing less. Less is more, because we don't want to remove that coping strategy. Instead, we want to simply provide a better option. And if we can do that, then we're helping our clients. Dax, I see you. Yeah, yeah.
We just want to tone down the nervous system. It's the safest way to go. That's what I've learned.
Yeah. How many of you all have gone through optimizing assessment? Optimizing is, yeah. So for those that haven't, I highly suggest it because optimizing assessment gives you a framework, a template to look at movement.
Are you talking about your course, Joseph?
Yeah, we have to have a template for movement when we're working with our clients. Just like the template that I used with Yolanda in scapular mobility. If we don't have a template, it's going to be very difficult to create benchmarks in any kind of assessment process. We have to have some sort of foundation.
Are you talking about the handouts or are you talking about the course the other course you have?
The other course I have, Optimizing Assessment, is a movement course.
I think I did that a while ago. I probably need to review it.
Yeah, it's more than just review it. We need to own the material. We need to practice it. We need to feel it. It needs to be within our experience so that it becomes a tool that's intuitive rather than something that we have to cognitively analyze. This becomes a very big piece of the process of therapeutic intervention. Are we analyzing? Ever heard of, what is it? Analysis paralysis, right? So analyzing things is a left brain process. Right brain is where our intuitive self is, and our creativity and these aspects. And so when we're interacting with our client, we actually want to be in the right brain. That's going to give us the most information. If we're in an analysis process and we're in that left hemisphere of our brain, we're going to be missing a big spectrum of the communication through limbic resonance that we're getting from our client. And this becomes something to really consider. This is why in our personal practice, when we own the movement, then we don't have to think about it. It becomes second nature. We can see it in people very quickly in the way that they're organizing and the way they're moving, and we don't have to think about it so much. This is why that white space exercise that's so important that we get taught in choreography and dance becomes something that's really important when we're looking at structure, because the white space gives us that interpretation where the body isn't. And that becomes, and it also gets us in our right hemisphere. Well, you guys have been great, and I know that I went a half hour over. And so I appreciate y'all hanging out with me. And if you have anything else, any other questions and stuff, you know, I love this work so much. And so it's always just such a joy for me to share. Thank
So
you.
I'm wondering about your limbic work. Do you do a course on that, or is that something that people have just learned from you or have taken that you're kind of like, go over here and that's what I have? So I'm wondering about the limbic work, where that's from.
The majority of the limbic work that I teach in the mentorship program because people, I need to know that there's enough of a foundation to get into it. I've been asked to create a limbic course that will just, you know, about the limbic system. But here's the thing, a tool on its own is dangerous without knowing when it's appropriate to apply that tool. And that's the whole framework that we develop in DNA. I just wrote a blog about that. John, if you're still here.
Hey, I'm here.
Yeah, thanks. So John, I was at John's facility in February teaching DNA. And John had a very potent experience with the particular limbic work that I do. And there's a framework that needs to occur before we apply it. Because if that framework isn't in place, there's going to be an unknown variable in what the results are going to be. John, could you say a little bit about your intra-abdominal pressurization, what we did when we did that work with your rib cage, and how all that changed when we did the limbic work, when we did the full mapping?
Yeah, well, sure. When we first started to map out all of the movements that are associated with building intra-abdominal pressure, I mean, really, it was like, 9 out of 10 were sort of failing. So, and I was a little bit surprised because here I thought, well, I've really been working on my breathing and know a lot about building intra-abdominal pressure. But sure enough, when assessed, there was quite a bit of compensation happening. So initially, early in the weekend, we had. I mean, this was not very surprising, but I TL'd the scar, and a lot of tests improved. But through the use of this assessment process, we didn't just stop at the scar. We asked the deeper questions. Where's this dysfunction coming from? Limbic, physiological, structure, and sure enough, there was a limbic association. And so, like for example, I TL'd forehead, the Bennett points, and one by one, all of these tests became strong. So that sort of was convincing. And then we went down the rabbit hole a little bit to find out exactly what association needed to be addressed. And then once it was, sure enough, not only did the assessment tests get stronger, but just the quality of my breathing changed, where I could actually fill that pelvic bowl first and have it rise up, as opposed to initiating it higher in my rib cage. So it's pretty powerful.
Here's the thing. We do not know if working on the association in the clear on its own is going to change the benchmarks of movement. It's an unknown variable. It's only known if all those benchmarks of movement are cued into the nervous system at the time that you engage the limbic system. Why is this important? If we think about the fractal of a coping strategy, it is a learned response. The nervous system learns how to use each one of those components in that strategy as a way of supporting that association. In each one of those points, there are the various afferent signals that are related to that association. If we clear the association if we work on the association in the clear, and the nervous system receives stimulus from those different afferent signals. The nervous system is going to go, oh, I remember how to deal with this. And it goes right back to where it was. And so we have to get this fractal or this spectrum of these inputs cued in so that when we do apply a corrective strategy, that it all can change in one fell swoop rather than, oh, it got better and then it came back. Well, why did it come back? Because the whole fractal of the compensatory pattern wasn't cued in. And this is like the big elephant in the room. This is why clients will return to us with the same symptoms. It's because we're either not addressing the right driver, or the nervous system isn't cued appropriately to all the different pieces that are involved. My teacher Jocelyn would say, you have to dissect enough of the problem so that when that person walks out of your office, that the movement of walking out of the office doesn't remind the nervous system how it had to cope with the original event. Remember, Scott, how Jocelyn would frame that?
Yeah, totally. She would pick apart everything. She would assess, and then make one, maybe two corrections, and all the pieces just fall in the right place they need to be. Same thing with DNA. If you haven't taken DNA, I know a few of you have on this webinar, that I fully advise it, because it really opens up the lens to how you can actually treat people with, like, just really asking the right questions, asking more questions, take that client further down that rabbit hole. Just don't fuck it up, pardon my language, but just keep asking all the good questions. But yeah, totally agree with it.
Now my intention with this isn't like as a sales lead-in. But what I really want to do is provide you all with good information and to recognize that we all have our gaps. Like, for example, my particular gap is I'm very strong at doing structural work and limbic work, but you get me into some of the aspects of physiology and hormonal balance work, that's not my wheelhouse. You get me into doing visceral work and looking at organ movement and the organ rhythm, planes of movement that organs move in. I'm great at that kind of work. But someone has an endocrine issue, I can pair the glands and tell you who the main driver is and who the main and who the secondary is. But as far as giving them what they need, no, I'm going to refer them out. And so this becomes an important part of knowing where our strengths are. And from that, we can also discern, oh, this isn't in my wheelhouse. Oh my gosh, you guys are great. Anything else? Thank you, John, for that share, by the way.
You're welcome. Thank you.
Better.
Appreciate it.
I would like to add, I don't know if this is appropriate, if anyone would like to get and do any online stuff, to do some practice, I'd be more than willing to throw myself into the online world if you so desire, but not to go into emotional stuff, but just to see, just to play. I don't know if you guys have been practicing with other practitioners. I've been practicing with friends and longtime clients and other practitioners, and some sessions go well, some sessions don't go so well, but ultimately, like, just the practice is, I think, paramount. So I would offer myself if anyone wants to practice.
That's excellent.
Nice.
I highly recommend that. Practice, practice, practice. And if
Yeah, and when we're all together in the same group, it would really work out as well too, because we're all on the same page.
Yeah. If you guys have any questions about your practice and what's coming up, what your experience is. Let's bring it to this process. This is about giving you guys more tools in your tool belt so that you can work effectively with your clients. Now, sometimes that doesn't necessarily mean acquiring something new. It's just putting things in context and putting things in order. And that's what I call a shift in the lens.
It might just work if those that are interested in practicing, just putting their email or something like that in the discussion, because it's kind of just hard to find Alexis in USA, you know. So if you're interested, maybe that's a way of trying to do it to the connecting type of thing, is that you post it in discussion and then whoever can contact.
That would be great. So Yolanda's talking about that there's the discussion aspect in the Think of It forum where people can ask questions. I know Carrie has posted there. Daniela, I think, posted there. Alexis, you posted there. And so that's a great place. Scott, I'm going to ask you to post there and create a thread about creating these
Will do.
these groupings.
Will do.
And
I've had I've seen triads and quads, meaning 4 people get together and 1 guy watches or 1 lady watches, but I've had better success with just dyads, with just 2 people going back and forth. Otherwise it becomes a social hour and not a lot of stuff gets done. What do you do? Oh, I do this. What do your kids do? Just get together and focus. That's one thing that I found. I've even had, I've asked mommies to please have their kids leave the room unless you can really focus. Otherwise it becomes just, we're all quarantined. So, but yeah, it works well, but I'm willing to do it and I will definitely set that up. But you guys, I got to bounce. Great seeing everybody. Joseph, thank you.
Thank you.
I'll be in touch.
thank you all so much.